All right, everyone, we're going to get started. If I could ask everyone to take your seats. All right, thanks everyone for coming. And unfortunately, we didn't make it to the full conference without rain, so I apologize on behalf of all of Vancouver today. So it's my pleasure today to introduce our clinical sciences plenary speaker, Joel Palefsky. So, c'est mon grand plaisir aujourd'hui de vous présenter notre présentateur pour la session plénière en sciences cliniques, le Dr Joel Palefsky. Il est professeur en médecine à la faculté de médecine de l'Université de Californie à San Francisco. C'est un spécialiste reconnu à l'échelle internationale en matière de biologie moléculaire, de traitement, de pathogénèse et l'histoire naturelle des infections anogénitales, à papillomavirus humain. Sorry, it's been a while since I spoke French. Notamment dans le contexte des infections au VIH. Il est directeur de la première clinique au monde qui se consacre à la prévention du cancer anal. Il a été le pionnier des méthodes de diagnostic et de traitement de la néoplasie intraépithéliale anale, AIN, et a été un des promoteurs de dépistage et du traitement de l'AIN dans les populations à risque. Ainsi, il est aussi l'auteur de plus de 310 publications. So Joel Palefsky is an internationally recognized expert on the molecular biology, treatment, pathogenesis, and natural history of anogenital HPV infections, particularly in the setting of HIV infection. He's the director of the world's first clinic devoted to prevention of anal cancer, the Anal Neoplasia Clinic Research and Education Center at the UCSF Cancer Center. He has pioneered diagnostic and treatment methods for anal intraepithelial neoplasia, AIN, and has been an advocate for screening and treatment of AIN in high-risk populations to prevent anal cancer. And many of us in this room who do this work have learned a lot from him, and he's been a mentor for many of us. He's also the principal investigator and the chair of the Anal Cancer HSIL Outcomes Research Study, or ANCHOR, which is a multi-site NIH study designed to determine whether treatment of anal cancer precursor lesions prevents the development of cancer. And in his spare time, he has also published 310 publications. And he made it very, very clear to me last night, even though he's geographically situated in California, that he is a Canadian, originally from Montreal, and did a lot of his training there. So without further ado, I'd like to introduce Dr. Palefsky.
Merci beaucoup, Troy. Ça me fait du bien entendre une introduction en français. So I am going to switch. We don't get too much chance to practice our French in California, and I'm notoriously deficient in Spanish, malheureusement. So the topic for this morning is HPV interactions in the presence of changes in the HIV epidemic and how they're going to play out in terms of the HPV-related cancer epidemic that we're seeing. And my talk is on both the promise and the challenges because there are really new issues arising, but at the same time, I think, increasing hope for change. So here are my disclosures. I've done some work with Merck & Company. This is predominantly on the quadrivalent vaccine that I'll be talking about a little bit, and work with the following companies on trying to develop new therapeutic approaches to treatment of AIN, because one of our big problems is we're still in pretty medieval about how we treat these lesions. We are predominantly looking for them and removing them through burning them off, which is not very elegant, and we have a good target, which is the gene products that are made by HPV, and so we really need to do better with that. So I'm going to first start by giving you an idea of why I'm here and why you should be thinking about anal cancer. It really is not on the top of most people's minds, and it's certainly not a popular cocktail party conversation. I'm going to spend some time talking about how we think about reducing the incidence of this disease, both in terms of primary prevention, i.e. vaccination, to prevent the acquisition of the agent that causes the whole problem, HPV, and talk about secondary prevention for those of us who are too mature to have received the vaccine and who may already have been exposed to HPV and developed lesions due to it, and then say a little bit about treatment. So one thing that's really important to understand about cancer in general in the setting of HIV and then about HPV-related cancers is that they are becoming more important and not less important as the epidemic matures. So we've dealt with the most pressing problem, which is HIV infection, and people, of course, are living longer and better thanks to antiretroviral therapy. And now we have different issues to deal with, and the most important of them is cancer. Cancer is now the leading cause of mortality amongst HIV-infected men and women. That's one very big change. The second very big change is the change in the spectrum of those cancers, because initially they were the ones most associated with immune suppression, the so-called AIDS-defining cancers, Kaposi sarcoma, non-Hodgkin's lymphoma. But that has changed too, as we've done better at controlling the immune suppression. And the big change, I'm not sure you can see, yeah, is the green ones have gone down. Those are the AIDS-defining, and the blue ones are the non-AIDS-defining. They're becoming both more common and a higher proportion of the cancers overall. So that's really a major change. And then if you look at the non-AIDS-defining cancers in particular, it's the gray ones that are the HPV ones, and you can see that they are not declining, but instead increasing a little bit over time, so that the absolute number of cases of these cancers in settings where there is no active screening is continuing to increase and certainly not decreasing. Now, just a word of reminder to all of us about HPV. Cervical cancer globally, of course, is the big elephant in the room. It causes by far the most mortality due to HPV-related cancer in the world. But if you remove cervical cancer from the equation, actually male HPV-associated cancers are more common than female-associated cancers. So penile cancer, of course, is a male problem. Vulvar cancer, of course, is female. But anal cancer is practically an equal opportunity afflictor. It actually causes more disease in women than in men in terms of absolute cases, because most of the research was done initially on HIV-positive people, particularly men. I think in the press's eye and in the public's eye, to some degree, anal cancer has become conflated with a male disease. It is not a gay male disease. It is an equal opportunity cancer, unfortunately. And I'll show you some data on women which suggests why it is such an important disease in women. So here is the organ du jour, on which we are all sitting, except for me. This is actually an interesting example of how Netter, who's like the god of anatomic drawings, got it wrong. Because if you look at this, you have the impression that here's the rectum over here, sort of, yep, there you go. Here's the rectum, and here the anus begins, and actually this isn't the way it really is. This is the dentate line, which looks very visible in this drawing, which we don't actually see very clearly most of the time when we do an examination. And this is the squamocolumnar junction up here, which is where the anus actually starts. You can hardly see it at all in this, but this is what we do see very clearly when we examine patients. And so, in fact, this squamocolumnar junction is just like the cervical transformation zone, which is the primary target for HPV in the cervix. And this is, in fact, where most of the lesions actually arise. They're up here, but the anus does go all the way from the end of the rectum, the squamocolumnar junction, to the dentate line and beyond, and then to about 5 centimeters past the opening of the anal verge. So it's quite a large organ and replicates 2 different organs, in fact. The anal mucosa is similar to the cervix, the inside part, and the outside part is more like the vulva. And so the diseases have the characteristics of both of these organs. At any rate, it is not a simple thing to do an assessment of this disease. Certainly, you can't learn a whole lot. You learn some by just spreading a person's cheeks and looking perianally. Most of the action is internal, where it can't be seen. And so we have adapted / stolen our techniques from the gynecologists to assess anal disease. And so we typically do anal cytologies. We do not call them anal pap smears, because paps are really for the cervix. We call them anal cytologies, and we basically blindly put swabs up people's rear ends and stir and try and dislodge cells. And after that, the specimens are processed just the same way as a cervical pap smear. And then if those are abnormal, we will do the next step, which was also stolen from the gynecologists, which is to put a scope in and then use a colposcope to try and visualize the source of those abnormal cells. We do not call that colposcopy, even though we are using a colposcope, because kolpos means vagina in Greek. And so we call that a high-resolution anoscopy, or HRA. And then we biopsy the lesions that we see to determine the actual grade of severity, and then make treatment decisions based on that. So one of the important things about anal cancer is that in the general population, I'm not talking about HIV here, its incidence is increasing in both men and women, and has been since the 70s. It's going up by about 2 to 3% per year, and has almost nearly doubled during this time. It is still a rare disease in the general population. You will find it on the order of about 2 per 100,000, a little bit more common in women than in men. And this trend is shown here on this slide. But one of the disturbing things is that even though, even as it's continuing to increase, despite many advances in therapy for anal cancer, in fact, the survival rates, as you can see on the bottom, really haven't budged very much from the early 70s. So people are still dying of this disease. It is often found at an early stage, and when it is in an early stage, about 70% of the time people will survive it. And that sounds like good news, and of course it is, but it's what I would call a Pyrrhic victory, because the treatment for anal cancer is nasty. It is chemoradiation therapy for the most part, and the radiation therapy causes a lot of problems, including pain and bleeding that last for many, many years, associated with a lot of depression, various forms of trauma, changes in quality of life. So people who say to me, well, it's such a rare cancer, why don't you just wait for the cancer to develop, diagnose it, and treat it, because people will survive, that is not the right answer. We want to prevent the cancers in the first place. So this trend that I was telling you about as far as increases in the cancer rates, we see that in just about every country in the world where they keep good data. And you can see the different curves for the men and the women, but the trend is upwards in pretty much all of them. So why hasn't anal cancer actually declined in the setting of antiretroviral therapy, just like KS and non-Hodgkin's lymphoma? The reason, I think, is shown on this slide, and the model that we have developed over the years shows that people get HPV infection early on after initiation of sexual activity. This is a fact that's true in the cervix, it's true in the anus. And most likely somebody's going to get HIV after they get their first HPV infection. Not always, but most of the time. And as long as they remained untreated and continue to have ongoing immune suppression, as in the early days of the HIV epidemic, people would progress from that initial infection through the cancer precursor, high-grade squamous intraepithelial lesion, or HSIL. That's the same as what we would call AIN2 or 3. And then there's a period of time where it sits there before it progresses to cancer. Since people get HPV infection early, like within their first few sexual partners, so that'll often be in the teens or the early 20s, we also know that the high-grade lesion develops quickly also, within a year or two. And so there's a very long latency period between HSIL and progression to cancer. But in the olden days, people often died from HIV-associated morbidity before they had time for those high-grade lesions to progress. Well, thankfully that has changed, and people are living nearly, if not completely, normal lifespans. And so there's time for this high-grade lesion to progress to cancer in the absence of an active screening program, which is basically what we have now. There are no guidelines for screening for anal cancer, and so the great majority of the at-risk population are not actively being screened. Furthermore, we know that when people go on antiretroviral therapy and they get great immune reconstitution in almost every measurable way, that is not the case for the high-grade disease. We do not see regression, for instance, of people who already have disease. It basically sits there, doesn't really change much, sometimes even gets a little worse. So we have a perfect storm of people who have HPV infection before they get HIV. They're living longer, their high-grade disease is still there, and they're not being screened. And so this was predicted, actually. We predicted it about 20 years ago that this was going to happen, and this is, in fact, what has happened. And just to give you a sense, I told you that the incidence is about 2 per 100,000 in the general population. Well, in HIV-infected MSM, which is the highest incidence group, it was reported a few years ago to be 131 per 100,000 in the NA Accord study. It was reported to be 46 amongst a group that is never thought of when it comes to risk of anal cancer, which is men who have sex with women, and was also elevated in women at 30 per 100,000. To put this in context, in the US, our current rates of cervical cancer in a screened population of women are about 6 to 8 per 100,000. So these numbers are really unacceptably high. This shows you what happens with a bunch of different non-AIDS defining cancers. I'm sorry if you can't see this at the back. Anal cancer here is in the top left, and what I want to just point out here is that just the difference in the curves between the top curve and the bottom curve, where the top one is in the HIV positive population and the bottom is in the general population. So that's one important point. It's wider than for most of the other non-AIDS defining cancers. What you cannot see from the back is the actual numbers on the y-axis, because these are some of the most common cancers occurring in this population. And in fact, if you compare the actual absolute number of cases, you can see the number for anal cancer. It's not quite as common as lung cancer, but it is more common than prostate cancer. And it is, at this point, the most common potentially preventable cancer that we have in the HIV-positive population. So one of the other changes that's occurring, which is really important, is the demographics. What is that? Basically, people are getting older. That's a great thing. As you'll see, at least in the US, a high proportion of people are over the age of 50. Anal cancer is one of those cancers that increases in people as they get older. You can see that arrow where it shows in the purple curve the incidence of anal cancer as a function of age. In women, it goes up. So in 2015, it was estimated that more than half of people living with HIV and AIDS were over the age of 50, and that actually translates into about 311,000 people. So that's one important thing. And then it is also known that people with HIV and AIDS may be aging prematurely. So this may be compounding the fact that happens for the cardiovascular system, the nervous system, and it may well be happening for immune response to HPV-related disease too. In fact, there is some data suggesting that anal cancers do occur earlier on average in HIV-infected people than uninfected by about 4 years or so difference. So where is this going? I think there are a lot of potentially conflicting factors going on here. And what I did here was I put factors that we have no control over in red and the ones that we have the most control over in green on the left. Some of them, I think, are pushing us towards an even bigger increase, and some of them, fortunately, have the potential to dampen or even reduce the incidence of cancer. So age is a factor. We have no control over that. Nor, at least right now, the accelerated biological aging that we see, and I think both of these are increasing the risk of cancer. There is some good data to suggest that a lower nadir CD4 level is associated with increased risk of cancer, and I put that in yellow. It's kind of in between green and red because, yes, I think we can have people with higher nadir CD4s now that we're introducing ART earlier, but the vast majority of people, at least in our setting, have already acquired HIV and were already put on antiretroviral therapy under the old guidelines, and so their nadir CD4 can't be controlled at this point. Lower current CD4 level probably helps some to control that, and time on effective ART is also important. Alexandra de Pocamandi, who's here, and her group did some very nice work on that, showing that it helps with anal precancer lesions. Earlier initiation of ART will probably help, but we don't know for sure. That's in the possibly category. And then I have in green screening. So I put definitely for cervical. We know that cervical screening helps We hope that anal screening will help, but we don't know for sure, and that's the purpose of the ANCHOR study that I'll say a few words about a little bit later, and which Troy mentioned in his introduction. And then, of course, HPV vaccination is the long-term answer to everything HPV. If we vaccinated everybody who needed HPV vaccine now, we would not see HPV-related cancers in the future, but that doesn't help everybody who's already got HPV at this point. So what can we think about where this is going in the future? And the two best indicators are HPV infection and HSIL. If you don't have HPV infection, you're not going to get HSIL, and if you don't have HSIL, you're probably not going to get cancer. Well, here the news is pretty sobering. From the SUN study, and these data are very similar to most other studies in the field, if you look at the bottom part, you can see that amongst MSM, the prevalence of HPV was 96% in a single testing. This is in a multi-site study in the United States. They found 90% of the women had anal HPV infection, and about 60% of the men who have sex with women have anal HPV infection. So you may be wondering, how are women getting HPV infection? And it's maybe the same answer as how men who have sex with women are getting anal HPV infection. Probably some are having receptive anal intercourse. We know that happens, there's no question about that. But we also know that many women say they've never had it. I believe them. And there's some interesting data from Tasmania that show that women who wipe themselves from front to back, as their moms taught them, to avoid urinary tract infections after going to the bathroom, have higher rates of anal HPV infection than women who don't wipe themselves from front to back. So this is a problem. If you get anal HPV infection or its consequences, you can definitely say, it's your fault, Mom, here, okay? Now, I'm not advocating you change because I haven't seen the cost-benefit analysis of preventing urinary tract infections versus anal HPV stuff, so just saying. So it may be, for instance, that men who have sex with women, although some do have anal intercourse, may also have had it spread from their own genital tract, potentially the penis. The other sort of, I think, alarming thing is that, particularly in the HIV-positive population, anal HPV infection is more common than cervical HPV infection. This was a study we did a number of years ago, and the results have been replicated again many times over, where in yellow it's cervix, in purple it's anal, and these were women at various stages of CD4 at the time, and you can see how incredibly common anal HPV infection is, similar to that SUN study. What about HSIL? So this is a slide using some older terminology. We did this study in San Francisco. This is the only population-based study. We used random digit dialing, and we brought in HIV positive and negative MSM. And amongst the HIV positive MSM, 43% of them had a high-grade lesion. So this is enormous compared with, say, the prevalence of cervical high-grade lesion in a healthy Vancouver population of women. So this is alarming, and most of our subsequent studies show rates of 50% or more prevalence of this high-grade lesion. And in women, earlier studies showed a lower prevalence, but we just completed a study as part of the AIDS Malignancy Consortium in which women were studied at multiple sites around the United States, and at least now, perhaps a combination of increased incidence and time, which allows the anoscopists to get better at what they do in terms of finding the lesions. Right now, the data show about a 30% prevalence of high-grade disease amongst HIV-positive women. Why is this happening? So, combination of features. Some of the risk factors that put people at risk for HIV also put them at risk for HPV, some of the sexual risk factors. There's obviously attenuated immune response. One that is relatively understudied, and I'll show you one slide just to veer a little bit to some basic science, is a direct interaction between HIV and HPV at the tissue level in the anogenital mucosa. So even when people have complete control of HIV as measured by an undetectable viral load, you know there are reservoirs, and we talk about the CNS, but the anogenital mucosa may also be a reservoir. There is HIV in the anal mucosa. We find it when we look. And there is also low-level inflammation going on there related to both HIV proteins being expressed there, TAT and GP120, and interferon and TNF-alpha. So we asked the question, if you show the epithelium some HIV proteins, does that affect the ability of HPV to get into the tissues? Normally there's a zipper on the top of the epithelium. They're called tight junctions. And it's been shown that in vitro that TAT and GP120 actually unzip that zipper. So we tested that for HPV, and in the slide I'm going to show you what we did was we made HPV particles and labeled them in red. HPV normally infects at the bottom of the epithelium. And so we wanted to see if we had any red signal at the bottom of the epithelium when we took biopsies from people. These were oral biopsies, and we grew them in the laboratory and kept them intact for a few weeks. So we took these red-labeled HPV particles and we exposed the tissues to these HIV proteins and asked whether HPV was better able to get into the tissue. So here you can see on the left, green, which is the control. There is no red. We did not add TAT. But when we added TAT to these tissues, you see that band of red down there at the bottom. That's the basement membrane here in the lines, and this is all HPV particles that have gotten into the epithelium. So in addition to not being able to control HPV, we think that these low-level HIV infections or presence of HIV in the anogenital mucosa increases the ability of HPV to get down there. So turning to how to deal with this problem. Primary prevention is the answer in the long term. Again, it's great for people who have not yet been exposed to HPV or relatively minimally exposed. The currently available vaccine is the non-valent vaccine, which has 7 oncogenic types and 2 non-oncogenic, HPV 6 and 11, to prevent warts. And a lot of excitement going on in the vaccine arena in the last few years. The Advisory Committee on Immunization Practices recommends, firstly, vaccination of men and women equally as a routine, and I know this is happening more and more here, so congratulations. It is also recognized, thanks in large part to work done here through Simon Dobson and colleagues, that 2 injections may be enough, but that is only true when you're 15 or when you're 14 and under at the time of vaccination. If you're over 15, you're already over the hill from an immunologic point of view, and you need 3 injections. That is also true, though, regardless of how old you are when you're HIV positive. So we still recommend 3 injections for HIV positive people. And there's even a study going on right now in Costa Rica to look at the efficacy of 1 dose. So it's possible that if you're under 15 years, you may end up getting 1 dose, but it's still too early to say. So as far as HIV positive people are concerned, I strongly recommend vaccinating everybody 26 and under. In some countries, it's recommended up to age 45, but for sure at 15 and under, it's safe. It probably produces lower titers. Dr. Money and colleagues produced a nice paper on HIV positive women. We still don't have a lot of data on efficacy. I think you guys did a great job at teasing some of that out. And again, we do recommend 3 doses for people who are HIV positive. These are some data that just show how well the vaccine is working in real life. These are data from a group from Quebec. It's a meta-analysis showing how the rates of warts as a proximal indicator of the vaccine efficacy have come way down in a birth cohort that was highly vaccinated on the left, on the top upper left. And then the older women have good responses too, but progressively less. And the one on the right is too old to have been vaccinated. So they don't see much effect. But the other cool thing was that the boys in those places also showed reduction in warts, even though at the time this was done, there was not a lot of male vaccination. So there's also herd immunity. And in settings on the right columns where there is not such great uptake, we don't see nearly as much benefit in the general population, either in girls or boys, in terms of reduction of warts. So secondary prevention is really, unfortunately, our primary mode here for the populations that most of us deal with. And what we're talking about here again is cytology screening, just like in the cervix, where if you have any abnormality, including atypical squamous cells of undetermined significance or ascus, then we recommend high-resolution anoscopy with biopsies. If somebody has a high-grade lesion, our practice right now is to either put them in a study or treat it. And if they have low-grade disease, we tend to leave it alone unless they're symptomatic, unless they have symptoms. If they have a negative cytology, because cytology has limited sensitivity, just like in the cervix, we recommend repeating it. And that means every 12 months if you're HIV infected, and every 2 to 3 years if you're an at-risk person, but HIV uninfected. And this is one of my colleagues using the colposcope performing high-resolution anoscopy. One other very important point is that most of us don't have the ability to refer people for HRA. It's an uncommon procedure because it takes so long to get good at it. But we all have an important diagnostic tool at our fingertips, so to speak. In fact, we have 10 of them. And so I'm urging the clinicians in the room who see HIV-infected people to do at least an annual digital anorectal exam, a DARE, not a digital rectal exam, digital anorectal exam. We're feeling for the usual things we were taught to feel for when we do a DRE, to also focus on the anus because we feel hard lumps and have diagnosed cancers that way that would otherwise have gone undiagnosed. And you're doing, I think, your patient a very important service. So our screening list, fortunately, is not everybody. It is pretty well defined. It's basically anybody who's got HIV, men or women, regardless of how they got it. It's people who have receptive anal intercourse, HIV uninfected MSM, women who are sexually active with anal intercourse, and women who have a history of high-grade cervical or vulvar precancers or cancers also at high risk. Other forms of immune suppression too, such as solid organ transplant. We recommend that people don't get screened until they're a little older. Just like in the cervix, we've been pulling back about being too aggressive with young people. So we recommend starting screening in an HIV-infected population at age 25. And since the cancers occurred in even older age and immunocompetent people, you could potentially start as late as 40. The challenges are just like in the cervix, limited sensitivity, and so we're trying to do better, and one of them is through HPV testing. We've done some nice studies which suggest that very specific forms of HPV testing may be useful in conjunction with cytology, just like we're doing more and more in the cervix, but it's still at an early stage. As far as the treatment is concerned, I told you that we're still pretty unsophisticated about this. We need more HPV-targeted therapies, but our goal is to prevent cancer and also relieve symptoms when symptoms are there. Most of the time, these lesions are asymptomatic, but particularly if they're perianal, they may be associated with burning or itching and discoloration. So the treatment in the HIV setting is very challenging because the lesions are big, they're multifocal, and they come back a lot. It's what I call anal whack-a-mole. Okay. The therapy is primarily ablative, where we usually use a technique called hyfurcation or electrocautery to visualize the lesions after they've been biopsied and then send them and then basically apply the electric probe and zap them. Sometimes we use TCA, but not too often. The technique works okay. Any one lesion has about a 70% chance of being resolved, but the problem is, again, the lesion's popping up somewhere else, so the per patient success rate for any one treatment isn't so good, and we often have to do these techniques multiple times. Although they are well tolerated for the most part, you know, you still don't want to have a needle stuck in your bum, and what can I say? So the anchor study, it's what occupies me night and day now. This is the study to see whether what we're doing actually works. Does it prevent cancer? And to answer that question, we have to do a randomized trial. So we are doing a randomized trial where we are going to be screening 17,000 HIV-infected men and women to enroll more than 5,000 with biopsy-proven high-grade disease in 15 different sites around the US. That study is now ongoing, and we have now screened more than 5,000 people and are about to enroll our 2,000th person. So it's a massive undertaking, and I don't really have a lot to say yet, but I think it will have a major impact on determining whether this will become standard of care. So to summarize, anal cancer is increasing in the general population, and it is perhaps not increasing at the same rate as it was in the HIV-positive population, but it is still at least stable, maybe coming down a bit, but still way too high. And it will remain for the foreseeable future the most common, potentially, and I really do think it is, preventable cancer in the HIV-positive population. For primary prevention, the HPV vaccine is a great vaccine. Strongly recommend that you vaccinate all of your HIV-infected men and women, 26 and under. Over 26, I don't say you shouldn't, but I think that's more of an individual decision. We could talk about that if there are any questions about that. And again, I really think this is a very, very important thing to do. For secondary prevention, I think it's more challenging because there aren't a lot of resources out there to do this widely, but you can at a minimum do your digital anorectal examination. In all likelihood, screening methods will include HPV testing, just like they are in the cervix, but that's still a little bit too early to recommend at the moment. The treatment can be challenging, and you know, the anchor study, I think, will guide us in determining whether we can and should be subjecting people to the screening procedures and then the treatment. Unfortunately, since it's such a big study and it takes so long to recruit, we probably won't have an answer for a few years, probably 5. So you'll have to ask me to come back. Finally, I had the good fortune of being a visiting professor last summer at the University of Rome. So I lived for part of the summer in Rome, and I worked like Italians did. So I had time to walk around a little bit. And near where I lived were a big part of the massive walls that the Romans built, the Aurelian walls. And one of the things is I lived in a student neighborhood, and there's like graffiti everywhere. I could not believe how much graffiti there was. And this wall had just one little piece of graffiti, and I saw it and I had to take a picture. You'll understand why, and I'll read it for those of you in the back. I don't know if you can see that. So there's a car there just to give you some sense of the scale, and the top of the wall is up at the top of the picture. And then just above that, it says anal attitude, because that's what you really have to thrive in this particular business. So thank you very much for having me. Merci beaucoup. Et je suis très content de répondre aux questions.
Hello?
Yeah.
Hi. Can you clarify, so when women are going in for their Pap smears, should they be asking their doctor to do rectal exams as well?
So I believe that they should have a digital anorectal exam, yes.
Okay.
Whether they should have an anal cytology or not depends on whether there is someone in that community to whom the woman can be referred in case it comes back abnormal. If there is not, then I do not recommend doing that, because I think that would be wrong to do a test on which you can't act.
And should that continue even after cervical smears aren't happening for women who are postmenopausal or not sexually active?
I think so. You know, people have been pulling back in terms of U.S. Public Health Task Force guidelines on doing routine digital rectal exams. But I think, in my opinion, and this is just my opinion, not based on data or guidelines, women who are at high risk for anal cancer by virtue of the reasons I mentioned on the slide should have an annual digital anorectal exam. Okay. That's what we do.
Thank you.
So, hello? Hello? Yeah. So, among the cofactors you show for HPV, what is the role of tobacco smoking today?
That's a great question. So tobacco smoking is not a risk factor for HPV acquisition, but it is certainly a risk factor for cancer. It's known that tobacco smoking reduces Langerhans cell response to HPV proteins at the tissue level, and probably, of course, increases mutagenesis. So there's no question that tobacco is at least a risk factor for anal cancer once you've acquired HPV. And I thank you for bringing that up, because that is another mutable thing that we can do, which is ask about our patients' smoking habits and encourage them to reduce tobacco use.
Hi.
Hi.
My name is Sylvia Guglielmi. Thank you for a wonderful presentation. In one of your recommendations with regards to screening for HIV positive patients, you said that they should start at age 24?
25, yeah.
25. In our clinic, we've seen very young MSM, they're HIV positive, and in some of them there has been abnormal findings in their pap smears. Aren't you concerned that we're going to miss some individuals that actually have HPV earlier?
Yes and no. I actually think that a high proportion of those young men under 25 have high-grade disease and HPV infection. We just did a study on that, and again, more than 30% of them have a high-grade lesion. The point is, they don't have cancer at this age, and it's all about the cancer. So the idea is to delay putting them through this until you're going to impact on the incidence of cancer. When I started thinking about this, I was thinking we should start even later in the HIV positives, but I kept on getting reports that, oh, I had a patient who had cancer at age 28 or 29. It's not common, but it does happen. So I did reduce the recommendation to 25. I've never heard of a report of cancer under the age of 25. So the thought is, as long as they do get started, the chances are you will pick it up and treat it before it progresses to cancer.
I have a question for you.
Yep.
You put up your list of who we should screen, just going back to that list of criteria. In the absence of the results of the anchor study, do you think screening should, because there's no guidelines as you mentioned, should screening be rolled out to our patients without a proven intervention? That's my question.
Yeah, so our clinic has been doing this for 25 years, and we have been screening and treating. Well, we don't screen, we're a tertiary referral clinic. The primary care docs in the San Francisco Bay Area did cytology on a lot of their patients, then referred them over to us. So they're screening, and they can do that because we're available. We felt that it was an important thing to do in the absence of knowing, based on everything else that we knew about the natural history of high-grade lesions anywhere else in the body. So I strongly believe that these are precancerous lesions, and we were forced to do this because we didn't have the anchor study. Now that we have the anchor study, our approach is to try and put as many people as we can into the anchor study, but until we know the answer, and this is a philosophical thing really, until we know that we shouldn't, we do. Because those of us in the HPV world know that you wouldn't want to leave a high-grade lesion alone if you know it's there.
I guess a follow-up, though, is there's a lot of counseling involved around doing the swabbing, and what am I trying to say here? It's time intensive. If I were to screen all of my patients in my practice, which would be everybody based on your criteria, that would be at least 700 extra visits per year.
Mm-hmm.
When I don't know that the intervention is actually going to do anything, but just the process of having the swab done, not the process, sorry, but knowing the results, and now I have LSIL, and it's very anxiety and stress-provoking for
Yep.
patients. So do you think that screening really should just remain in the realm of clinical trials for the moment, or do you feel strongly enough as an expert that we should be going ahead and screening everybody?
Well, in the spirit of practicing what I preach, I think if you have talented anoscopists in your community, I would definitely screen people until I know I shouldn't. Again, that's my personal opinion, and depends on the ability of your clinic setting to handle the extra load that is undoubtedly involved. Yes, it is anxiety provoking, but the studies continuously show that whatever short-term anxiety is caused by this is replaced by longer-term, lower levels of anxiety. We've done a study of this actually as a sub-study of ANCHOR, and the people who are in our so-called active monitoring arm, who are not getting treated, are actually having higher levels of anxiety than the people in the treatment arm. So I think there's some balances here. And one thing that you could do to try and at least reduce the load in the system is use the cytology grade to triage people for at least who gets sent for high-resolution anoscopy. We know that if somebody has a high-grade lesion on cytology, that they really have a high-grade lesion sitting there somewhere. If they have a low grade on cytology, they may have a high grade, but we don't know. And an even lower likelihood if they have ascus. So if at a minimum, you did a digital anorectal exam, you did a cytology, I realize there's still some counseling involved, and sent only the people who have high grade on cytology, that's still a whole lot better than nothing, in my opinion.
Great, thank you.
Thank you, Dr. Palefsky, for a great talk, as usual. We'll now move on to our next plenary session.